To introduce our moderator for tonight, which is Dr. Matthew Elias, completed his medical school training at New York College of Osteopathic Medicine in 2008 and subsequently trained at the University of Connecticut in neurology. In his final year of training, he was named the chief resident. He completed a fellowship in movement disorder at the Leahy Clinic in Burlington, Massachusetts in 2013. He has been practicing in Morristown, New Jersey for the past 10 years and recently joined Atlantic Medical Group Neurology. Welcome, Dr. Matthew Elias, as moderator to the session. I'll let you take it from here. Thank you.
Good evening. My name is Dr. Matthew Elias. I'm a movement disorder neurologist here in Morristown, New Jersey. I'll be moderating our CME program tonight. For those with questions, please add them to the chat box for the Q&A session. Today, I have the pleasure of introducing our speaker, Dr. KJ Oommen. Dr. KJ Oommen was born and raised in Kutanad, Kerala, and completed his medical education in Thiruvananthapuram Medical College. Following this, he completed a neurology and psychiatry residency at the Arizona Health Sciences Center. He then completed an epilepsy fellowship at the Medical College of Georgia. After training, he worked for a year as an assistant professor of neurology at the Medical College of Georgia. He was then invited by the Department of Neurology of the University of Arizona to start the Comprehensive Epilepsy Program, where he directed the program for a period of 10 years. From there, he moved to the Department of Neurology at the University of Oklahoma. At the University of Oklahoma, he revamped the epilepsy program into a regional center of excellence and directed it for the next 14 years. He subsequently moved to Covenants Medical Center in Lubbock, Texas. During the last half-century, Dr. Oommen has trained hundreds of medical students, dozens of residents, and 6 fellows in epilepsy or neurophysiology. He served as a principal investigator for over 60 industry-sponsored epilepsy research projects, leading to the approval or new indications for a dozen new anti-epileptic drugs, as well as a DBS device for the treatment of epilepsy. He has written over 100 research abstracts and 40 peer review articles. He has been happily married to Solciety Oommen and has 2 children that are also physicians, one an epileptologist and the other a psychiatrist, and both are married to physicians. Dr. Oommen has been a life member of AKMG since its early days and has retained the position of vice chair of AKMG's continuing medical education efforts. We are privileged to have Dr. KJ Oommen give our CME lecture this evening. Thank you.
Thank you, Dr. Elias. Thank you for that introduction. I want to thank everyone for attending this presentation on neurostimulation. It's my pleasure to invite all of you to this meeting. First, let me thank the AKMG and the current president, Dr. Elizabeth Mammon, for inviting me to do this, and also for Dr. Elias for the introduction. I have to now live up to the expectation of that introduction, and I hope I can do so. And Dr. Mammon said this is going to be a dynamic speaker. I know my slides are going to be dynamic. I'm not sure about the speaking, but let us move on. I do not have any conflict of interest to declare. I want to disclose, however, that I have been a principal investigator for a couple of the therapeutic devices that I will be discussing today. I'll mention those in the course of the lecture. In the next hour, I'll be discussing some commercial products that are necessary for the purpose of this lecture. The logos on the products have been blocked in most cases to prevent the appearance of any conflict of interest. Some logos have not been blocked only to highlight their historical context and should not be construed as an endorsement of any of those products. Now, let me tell you, neurologists have been long known to make fancy diagnoses such as Charcot-Marie-Tooth disease, Wolfert-Lander disease, and hemiprosopometamorphic hallucinosis, but we have been ridiculed for a long time for being so short on treatment, because for many of those conditions, we didn't have much to offer. I'm here to announce today that the landscape of neurologic treatment has changed in the last 50 years. Those of you who have attended the last lecture by Dr. Pitchmoney heard that there is a new organ in us, the GI biota. I'm going to declare today that there is a whole new treatment modality that neurology has to offer the medical community, in addition to our millennia-old forms of treatment that we are all familiar with. With that, let me share my slides, and we'll get started from the beginning. So I'll be talking, like I said again, on neurostimulation therapies in neurology. Medicine has had 4 modes of therapies in the known human history: talk therapy or counseling, pharmacotherapy or use of medications, massage, exercises known as physical therapy, and surgical therapy. Neurostimulation with computer interface is fast becoming a 5th dimension in the therapeutic armamentarium of the practitioners of the healing arts. According to the International Neuromodulation Society, there were 66 neuromodulation devices on the world market as of a review in 2014. These include pulse generators, or IPGs, and non-invasive electrodes that stimulate the spinal cord, dorsal root ganglia and peripheral nerves, cranial nerves, cerebral cortex, deep brain nuclei, and some other parts, such as the retina. The indications range from chronic pain, Parkinson's disease, dystonia, essential tremor, epilepsy, depression, obsessive compulsive disorder. We also have assistive neuromuscular stimulation devices for physical therapy, for headache, addiction disorders, and restoration of memory. The targets include the subthalamic nucleus, globus pallidus internus, pedunculopontine nucleus for Parkinson's disease, substantia nigra, globus pallidus, and thalamus, GPR, and subthalamic nucleus for dystonias. Anterior nucleus of the thalamus and amygdalo-hippocampal complex are used for epilepsy management, and there are several others that are listed on there. For the sake of time, I will not be going through all of these. I'll be only concentrating on a few of those. The 2 MRIs that you see on the screen show some of these areas, and of course the detail is not that great, but those are the general areas where they are present. Now on the screen, you have a couple of gentlemen. Standing is Dr. Penfield, Wilder Penfield, and his electroencephalographer, Jasper. On the right-hand side is the Montreal Neurological Institute. These 2 men can be considered the pioneers in neurostimulation. During their surgeries on patients, many of whom were kept awake during the surgery, they stimulated different parts of the cerebral cortex and watched the response from the patients. And from that, they created this map known as the homunculus, or the little man. And you can see the sensory cortex on the left-hand side, on your left-hand side, and the motor cortex on the right-hand side. Except for proportions, the general scheme is the same. Now, the next slide shows a couple of people. One on your left side is Dr. Herman Flanagan, and on the right side is yours truly. Dr. Flanagan was trained by Dr. Penfield in neurostimulation, and during my fellowship in Augusta, Georgia, Herman trained me in the art of neurostimulation. And of course, this was direct stimulation of the brain like Penfield and Jasper did. Now on the screen, you have a picture of a bull and a man with a red rack next to him. The man is Dr. Delgado. And Dr. Delgado was born in Spain and got interested in neurosciences by the influence of Dr. Cajal and Golgi. They are known for their demonstration of the nerve cells in the brain by using the silver chrome stain. And he was influenced by the Dr. Golgi, and therefore he abandoned his desire to become an ophthalmologist like his father was, and then decided to become a neuroscientist. And then he went to Yale, where he got a fellowship. And after his fellowship, he stayed in Yale, where he did his neurostimulation trainings. And I'm going to share a video here.
Electronic mind control research is not new. A scientific milestone in this area came in the 1960s when Dr. Jose Delgado demonstrated remote control over a charging bull. By connecting a radio antenna to electrodes inserted into the bull's brain, Delgado proved that the animal's aggressive impulses could be thwarted by electronically manipulating the bull's muscle reflexes.
People realize the fantastic possibilities if from the outside we could modify the inside, could we give messages to the inside?
Were you able to hear the audio?
Yes.
Okay, yeah. So what you saw is Dr. Delgado, after having a bull implanted with electrodes inside its brain, enraging the bull with a red rag and then stopping the bull as it charged towards him with what he called a transceiver, which was in his hand. So this was a demonstration of behavioral control of an animal by electrical stimulation. And of course, that can be considered the early forms of brain stimulation. Since 1989, we can consider it the modern era of stimulation, cortical stimulation, neurostimulation, where the spinal cord stimulation was approved by the FDA. And following that, several devices were approved by the FDA, and new devices are still being approved. Here we have an example on the screen of a patient with a couple of eels on the face. The first therapeutic use that is recorded was in AD 46. Scriborius Largus was the Mesopotamian physician who used electric eels to treat headaches. What he did was he attached these eels to the patient's skin and used electrical stimulation through the electricity from the eel to take care of patients with headaches. He also had some of his patients put their hands in a bowl full of electrical eels. Can you imagine? So in 1989, as I mentioned, spinal cord stimulation was approved for chronic pain therapy. And since then, deep brain stimulation was approved for Parkinson's disease and essential tremor. Later, vagus nerve stimulator for epilepsy was approved, and DBS was approved for seizures later on. So there is a whole list of products now that are available on the market. Now, you can see, according to a research group, Global Growth Insights, a Maharashtra-based group, the sales of these devices jumped from 5.8 to 6.4 billion with a B from 2000 to 2024 to 2025. And it's expected to reach 13.9 billion by 2013. Spinal cord stimulation, deep brain stimulation, sacral nerve stimulation, vagus nerve stimulation, gastric nerve stimulation. These are the ones that lead the pack from bottom up. These are the different kinds of stimulators. So you really cannot see that very well. Spinal cord stimulators, they're on the screen. Of course, this will be available for you to review later if you're interested in learning more about it. We know that, let's go on to the stimulation therapies for chronic pain. And before we go on to that, let us take a look at the anatomy of pain. Sensations enter the spinal cord via the dorsal root. The small or the slow conducting C fibers transmit pain sensations to the spinal cord, and from there, it's passed on to the higher centers where we perceive pain. The large A beta fibers are fast and they transmit non-pain sensations. A major breakthrough occurred in 1965. Two researchers, Melzack and Wall, came up with this theory that the so-called, or what we thought was a hardwired mechanism where sensations come in through the dorsal root and efferents go out through the ventral root. They said the perception of pain and motor function are much more complex. They suggested this theory that when the C fibers bring in the sensations to the substantia gelatinosa rolando towards the projection fibers, they send a twig, an inhibitory interneuron, to an inhibitory interneuron, which is then inhibited, where the projection neuron is thereafter inhibited. So that means the sensation that comes in through this mechanism of inhibition of through the interneuron opens the gate for the passage of pain sensations to the central nervous system. And if you use a stimulation of the larger fibers, they act as an inhibition. They increase the inhibition on the projection neuron, and the sensation that's coming through the C fiber is blocked. So the sensation towards the brain is blocked at that point. So they called it the gate theory because the C fiber is able to either open at the gate, and the large fibers are able to close the gate for the passage of pain fibers. So this changed our understanding of the mechanism of sensory perception. The gate control theory was proposed in 1965. Now, based on this, of course, this theory was met with a lot of criticism, but 2 years later, the first reported clinical application came by. That was in 1967. They came up with an idea to stimulate the dorsal column. So you can see the electrodes going into the dorsal column along the intervertebral space, and they are laid on the dorsal aspect of the spinal cord where the large fibers are. And once they're stimulated, they inhibit the passage of pain sensations into the higher centers, and that was the theory. So what they did was they, using the electrode implanted on the spinal cord surface and the IPG, the impulse generator, they were able to send the signal to the spinal cord. Now, of course, they waited 2 to 4 weeks with the device, the IPG, stuck on the skin before actually implanting it subcutaneously, just to see if the patient responds. So in those who responded, they implanted it. Now, there are several studies that checked the efficacy of this mode of treatment, and I don't have the time to go into a lot of studies. I'll just touch on one. This was a prospective single-arm multicenter trial with a 3-month period of enrollment with 12 months of follow-up. They enrolled 100 patients, 55 qualified, and 40 completed the trial. And they used the so-called 3-point pain and sleep questionnaire to measure the efficacy. You can see here, at the end of 3 months, these were the results, 3-month results. The question was, do you have trouble falling asleep due to pain? And you can see in the first 3 months and the 6th and 12-month periods, there was a significant reduction in the trouble reported by the patients falling asleep due to pain. That was what we call the 3-point pain and sleep questionnaire. So this was one of them. And then baseline, and then 6 months later, you can see the effect is sustained, 6.8 down to 1.9 at the end of 12 months. And the last question was, how often are you awakened by pain in the morning? And then they kept track of these, and you can see in all 3 groups, 3-month, 6-month, and 12-month, there was substantial improvement in pain for these patients. So following this, several other products were approved. One of those, I will mention one more, which was the dorsal root ganglion stimulation. And that is because most of you who may have had encountered complex regional pain syndrome know how difficult it is to treat them. And the method of treatment for that particular condition was dorsal root ganglion stimulation. So the FDA approved the procedure for leg pain from other causes in 2018, and finally it was approved for peripheral neuropathy as well in 2021. So many products were approved in this period of time. Here is an example of the dorsal root ganglion stimulation. The wire is introduced onto the dorsal root ganglion, and then the IPG is connected to this wire, and they are stimulated. And of course, you can see that the results were impressive. You can see in the first month after the implantation, there was some change or some improvement in all the patients. That probably has to do with the surgery itself or the placebo effect, we don't know. But once the stimulation started, the patients who continued with transcutaneous nerve stimulation are on the bottom with the interrupted lines, and those who received the dorsal root ganglion stimulation are represented by the green line. You can see there was a clear separation between the two groups upon treatment. Now, these are several of the devices that have been approved since. Most of them had to do with miniaturization of the devices, and some of them had to do with the modification of the electrodes themselves. You can see the multiple contacts where the physician had the ability to control which one of these electrodes stimulate the patient. And then they also came up with arrays of electrodes, again, increasing the physician's ability to control the stimulation. So with that, I'm going to move on to deep brain stimulation for Parkinson's disease, which is the next device approved by the FDA. As you know, Parkinson's disease was described by James Parkinson in 1817, and the classic paper that he wrote still is the gold standard for the diagnosis of Parkinson's disease. And he said, involuntary tremulous motion with lessened muscular power in parts not in action, even when supported, with the propensity to bend the trunk forwards and to pass from a walking to a running pace, the scenes and the senses and intellect being uninjured. So these were the classic signs of Parkinson's disease: bradykinesia, tremors, and rigidity. What causes this? Well, later on, we learned a lot more, and you can see an example of the brainstem here. You can see the substantia nigra compacta, as it is called, in the midbrain, is dark in this picture. In patients with Parkinson's disease, they become pale, and this is because of reduction in dopamine content in that area. Here it is. Well, for a long time, we didn't have a good test for it. We still don't have a good test for Parkinson's. It's a clinical diagnosis, but there are methodologies that can help us diagnose whether it is Parkinson's or something else. This is a SPECT scan that you're looking at using ioflupane I-123. It helps to evaluate the dopamine transport system because this tags the dopamine transport protein, which can be imaged using a SPECT scanner. And you can see on one side here on the left side, the corpus striatum shines much better than on the other side. As you know, Parkinson's disease is usually asymmetric, so one side gets affected first. So here, this is a mechanism. This is not a test for Parkinson's, by the way. This is a test to differentiate Parkinson's from other conditions. So if the dopamine transport system is affected, it is more likely to be Parkinson's. That is the theory. Now, in the early days, before the 50s, before the 60s, there was no good treatment for Parkinson's, and many surgeons tried to do lesional surgeries for the treatment of Parkinson's. And in 1952, Dr. Cooper, while he was doing a lesional surgery, injured the anterior caudal artery in a patient. Well, the bleeding was profuse. He tied it up and got out. So what happened? Well, he was scared because tying the anterior choroidal artery is going to cause a massive stroke, and the patient was going to wake up with paralysis. That's what he thought, though. However, after the surgery, the patient had reduction in rigidity and tremor without any motor or sensory deficits. Well, it tells you that the anatomy that we learned in medical school, the vascular supply is not exactly the same in elderly individuals because too many things get diverted from small strokes and things like that. So in this particular patient, tying the anterior choroidal artery did not cause a massive stroke. Instead, the patient had a tiny lesion on postmortem. And lo and behold, here is a new treatment for Parkinson's. So Dr. Cooper went on to tie the anterior choroidal artery in 50 more patients with, of course, variable results at that time. Now, the problem with those surgeries in those days was the fact that it needed a big craniotomy. So many surgeons tried to devise equipment such as you see on the screen here, like stereotactic frames, through which they were able to create tiny lesions in the brain using this frame, introducing the needles or the device to cause the lesion through burr holes rather than doing craniotomy. So this is a device, a drawing by Dr. Lars Lescale of the Lescale fame of a stereotactic frame. So this made it possible for people to make thalamotomies, pallidotomies, and subthalamotomies, all through tiny burr holes. Now, the introduction of levodopa, later in combination with carbidopa, revolutionized the therapy of Parkinson's disease in the 60s. So because of the excellent results from the levodopa-carbidopa combination, surgery fell in disfavor. But it took only 5 years for people to realize that the response period, medication responsive, the so-called on time for the patients were getting smaller and smaller over time. And patients froze in between, and at other times they developed dyskinesias. So this was referred to as the on-off phenomenon. So because of that, stereotactic frames and brain surgery became more popular. And of course, precision placement of electrodes, precision placement of lesions, including the use of radiofrequency lysis, made it very practical to do lesional surgeries in patients. And then, of course, this became more popular again. So the pendulum swung in the opposite direction. So to more accurately target the lesional site, a French surgeon by name Benabid, himself being a physicist, began intraoperative recordings during his surgeries. And when doing surgery on a patient in 1987, he, instead of creating the lesion, first stimulated the area at a frequency of 50 hertz. Well, that's because people have tried stimulation in the past with low frequencies such as 50 hertz. On increasing the frequency of stimulation to 100 hertz, the patient's tremor suddenly stopped. So that was another eureka moment in the history of Parkinson's disease. So he worked in collaboration with Medtronic, a US company, and over the next 10 years, he developed the so-called Solitra. Solitra is the trade name of the device made by Medtronic in cooperation with Dr. Benabid. So the hardware is shown here only in its historical context, and it's not an endorsement of the product. So DBS received full US FDA approval in 2002. Here we see the effect of deep brain stimulation. There is a patient with an extreme case of Parkinsonian tremor with the medication taken off, which is what they do prior to surgery. So you can see the patient has severe tremor. And here is a patient who has the dyskinesia. Remember, some people freeze during the off time. Others have severe tremors if they miss their medication, and others have dyskinesias. Here is a patient on the left side before deep brain stimulation. Here is a patient after deep brain stimulation. So you can see there was a dramatic improvement in the tremor in the patients within the patient that you saw with essential tremor. So it was realized that the targets for Parkinson's disease and other motor diseases, movement disorders, and the targets were either the ventral median thalamic nucleus, the subthalamic nucleus, the corpus luisii, or the globus pallidus. So the ventral intermediate thalamic nucleus, VIM, it was found to be best for tremors and is still used as the target for treatment of essential tremor. The data are not yet clear on which target is best for Parkinson's disease. It is known that if you stimulate the subthalamic nucleus, medication reduction after surgery is a little better. If you stimulate the GPI, globus pallidus internus, it may slightly be safer for language and cognition. So these are things that we learned from experience, or the researchers learned from experience. How good is it? Well, best medical therapy versus DBS. This is a study published in JAMA in 2009. It's a busy slide, but let me bring you on to the essential portion of this one. Here is a 6-month mean and standard deviation for best medical therapy. This is the time where the patients were without troublesome dyskinesia and those with troublesome dyskinesia. You can see a big difference here between this 6-month result and this is the 6 months mean, and this is deep brain stimulation. This is medical therapy. So best medical therapy versus deep brain stimulation, there is almost a 50% increase in the amount of time without troublesome dyskinesia. There was a similar reduction in troublesome dyskinesias also for the deep brain stimulated group. However, things are not fine and dandy. The on-off dyskinesias after deep brain stimulation gets better. However, the disease Parkinson's disease is relentlessly progressive. All we are doing is improving the patient's state of on time by the therapy. One of the other problems with the Solciety was that it had a single lead. So for Parkinson's disease, two of the machines have to, two of the IPGs had to be implanted in each patient to stimulate both sides. Now, I mentioned that Parkinson's is a asymmetric disease, but over time, both sides are affected. And of course, with the Solciety, you could only stimulate one side. And in the early days, they had to implant both sides. So the company came up with another device called Kinetra. The Kinetra was able to stimulate both sides from a single device. So that helped the OR time required, and also the number of incisions, time under anesthesia, and all those things. So there was a big improvement. And there was also some other benefits for the Kinetra, which I will mention later on. So then other companies like Abbott got into the picture. So they got a indication for subthalamic nucleus and ventral intermediate nucleus for Parkinson's and essential tremor in 2016. And another company, St. Jude, you're familiar with, came up with their own device, and St. Jude was eventually bought out by Boston Scientific. But the next improvement by Boston Scientific for the DBS was the so-called directional leads. They came up with this idea to have the lead send signals in different directions. So If you have sprinkler systems in your yard, look at the blue bar on the top. By turning a knob on your sprinkler, you can change the direction in which the water is sprayed, and also they increase the area of spray, and you can even do a circular spray if you turn it long enough. So just like that, you can electronically change the direction of the signal with this directional leads. That was an improvement. I know. The reason is, of course, these are very tiny nuclei, tiny areas of the brain. And if you're on the left side or the right side or the front or back of the actual nucleus, you can still give effective stimulation through this directional lead. And that was the idea. So Medtronic didn't want to be left behind, so they came up with their own Sensite for directional stimulation. And then they came up with the so-called Percept, with the ability to record electrical activity from the nuclei and also give stimulation at the same time. So how do these things work? Stimulation of specific nuclei in the brain? Well, we don't know the answer, but it is believed that stimulation of specific nuclei in the brain alters the balance of inhibition and excitation by enhancing or inhibiting the effect of the specific neurotransmitters involved. Just like we have seen in the case of the spinal cord stimulation, there are mechanisms in the brain and in synaptic connections where you can either turn on or off certain stimuli and conduction pathways in the brain, which we don't quite understand well enough. And it is one of those mechanisms that are that is helping us with these devices, or helping patients with these devices. The third one I want to discuss today is the vagus nerve stimulation. Now, you can see I purposefully misspelled vagus nerve stimulator. It's not vagal nerve stimulator. It is vagus nerve stimulator. There's no vagal nerve in the body. So it has been known from animal experiments from the 1930s that stimulation, of course, EEG was available since 1928. And in the early days of EEG, people used EEG and brain stimulation for various purposes, of course, like they used to do ablative lesional localizations in the animals long time ago. Of course, but during those experimental days, it was shown that stimulation can result in changes in the EEG in the orbitofrontal cortex. You can change the interictal spike pattern. You can cause desynchronization of the EEG and even synchronization of the EEG by various experiments, and I won't go into those details. And they have also shown that seizures can be stopped by stimulation. Here is an example. Here is an ongoing seizure. Here is a stimulus, an artificial stimulus that is stopping the seizure activity. Of course, these are two different seizures, but the stimulation resulted in cessation of the seizure discharges. So it has been known for a long time. Orbital pressure was known to stop seizures. And orbital pressure, of course, was used for changing the heart rate by vagal tone changes, etc. The first animal studies in epilepsy were published in 1985, and 3 years later, the first human implant of a vagus nerve stimulator was made. And 6 years later, the European community approved vagus nerve stimulator for the treatment of epilepsy. So by 1996, a company, a Houston-based Texas company, completed 5 controlled trials on 454 patients and got the US FDA approval for the commercial manufacturing and sale of vagus nerve stimulators. So vagus nerve stimulator is a minimally invasive procedure. You don't have to go into the brain. You can attach the stimulus electrode or stimulating electrode onto the vagus nerve, as you can see here. There it is. you can attach it to the vagus nerve, and then using the IPG, and the company was called Cyberonics, using their IPG, they were able to deliver signals to the vagus nerve and look like this. So it was always the left vagus nerve was stimulated, the right having its connections. There was a fear that it could result in cardiac arrest. So it is always attached to the left vagus nerve. And you can see the negative end is distal and the positive and neutral are behind it. So the electrode is attached to the vagus nerve, and then it's tunneled through to the IPG, which is implanted in the chest. And that's the way it was implanted. The patients resulted with a couple of scars, one on the neck and the other on the chest. And those who wanted to have a scar on the chest hidden could have the incision made in the posterior wall of the anterior axillary fold, as you can see here. Some people are sensitive about their scars. So the 5 studies that I mentioned were the EO1 through EO5. And these were, the initial one was a pilot study, which was a single blind study of 16 patients. Then they did a blinded randomized study of 115 patients, then continued on with a compassionate trial with another 124 patients, and another blinded randomized double-blind active control study of 199 patients. So these are the 4 pivotal studies that resulted in the approval of vagus nerve stimulator for the treatment of epilepsy. Here are the results of that trial. And at 3 months, the blue bar, there was a 23% reduction in seizures in more than 50% of reduction of seizures in 23% of patients. That's called a responder rate. It's a statistical number. The number or the percentage of patients who have more than 50% reduction is known as the responder rate. So by 3 months, the responder rate was 23%. By 1 year, it rose to 37. And by 2 years, it rose to 43 and then remained stable. So in many cases of seizures, those of you who are treating patients with epilepsy know that there is a honeymoon period with most anti-epileptic drugs, and then the effect kind of decreases or vanishes. Some people continue to benefit from the drug. However, with the vagus nerve stimulator, you can see that the effect was sustained at least to about 43% responder rate. The initial indication was for adjunctive therapy in reducing the frequency of seizures in adults and adolescents over 12 years of age. And that's because the patients who were enrolled were 12 years or older. And that was the indication for partial seizures. Well, there were, of course, some side effects, infection. Some patients had to have explantation of the device, about 1.1%. The others were treated with antibiotics. Hoarseness of voice due to temporary vocal cord paralysis occurred in a small number of patients. And hypostasia on the lower half of the left face was another symptom. One patient had a systole out of 1,000 patients, but recovered. There was 0 mortality. Most of the adverse events were manageable, especially after the healing occurs, typically during the stimulation or on time. So the IPG can be programmed to go off every 3 minutes, every 5 minutes, etc., at fixed intervals for fixed number of times at fixed frequencies. So the physician had significant control over how the stimulus is delivered. Most of the symptoms were during the on-time phase of the cycle. And most patients had lessening of these symptoms over time. In other words, sometimes you can hear the patient's voice vibrate when the device turns on. And many of those symptoms can be controlled by changing the parameters of the vagus nerve stimulator. and the symptoms were similar across age groups. And this is another study, which was a multi-center, open label, long-term prospective observational study, where they had more than 90% follow-up. And you can still see there that the effect of vagus nerve stimulator, of course, these are patients who were implanted later. The very first group of patients did not do this well, probably because they were the most intractable patients. Now, when the device was given to the less intractable patients, nonetheless intractable, the improvement was much better, up to 66%, and it was sustained up to 36 months. Once the device is implanted, we can actually program it in the office. Here's a wand. It's a magnetic wand that's capable of talking to the implant over the clothing, and you can actually change the parameters after the surgical implantation. And typically, a smaller current is used in the first few weeks, and then you can slowly increase the current strength until patient tolerated, or until the patient cannot tolerate it anymore, or when the seizures stop. Again, how do these things work? Neurostimulation does work, as we have seen, for pain, for Parkinson's disease, and epilepsy, as you have seen in this case of vagus nerve stimulation. How do these things work? Well, the real answer is that we don't really know. But we know that vagus nerve is connected to the nucleus of the solitary tract, which has extensive connections in the brain. And it is this extensive connection that results in modulation of neural function, resulting in improvement of the patient. Well, that's a whole bunch of terminology. We don't really know how it works, but we know it works. So one of the elegant methods of showing the effectiveness was when VNS had an anticonvulsant effect in rats that had maximal electroshock seizures. Chronic acute lesioning of the locus coeruleus, when it was performed, VNS no longer was effective. So that made the researchers to postulate that the locus coeruleus is involved in anticonvulsant effect of vagus nerve stimulator. Again, it's not here and there, but it does show that these nuclei have something to do with seizure onset as well as the seizure control with vagus nerve stimulator. Several improvements happened since, and you can see miniaturization and wireless programming with newer iPad-like devices rather than the previously used heavy computers. One of the most recent developments is auto-stimulation mode. Now, we have observed that patients have an increase in their heart rate immediately before and during a seizure for reasons that we don't quite understand. Of course, the seizures, many of them coming from the temporal lobe, being close to the cardunculus, or the area of the brain that controls heart rate, may have some influence on this. So we can actually measure heart rate using this device. They made sensors that were able to pick up the heart rate, and from the rise in heart rate prior to the seizure and during the seizure, the device was able to, well, assume that here comes a seizure. So that was a seizure prediction mechanism based on heart rate. And then deliver a shock, making it a closed loop system. So that was the latest development in the use of vagus nerve stimulators. Now I see that it is only 7 minutes left, and we have covered 3 devices, and there are several more, but I'm not sure we need to go on. I think we can stop here Deep brain stimulation for epilepsy was similarly tried and was proven to be effective. And I was one of the investigators for deep brain stimulation for epilepsy. And subsequently, a responsive neurostimulator was devised that was also used for epilepsy. And we can talk about deep brain stimulation for epilepsy another time. But we have only 6 minutes left, and I think I should leave some time for questioning. Dr. Elias?
Sure. So it does not seem like we have any questions here in the virtual chat box over here, but I have a couple questions from your great talk so far. So what is the ideal candidate for vagal nerve stimulation look like?
Okay. The ideal candidate, of course, remember in the days of medical therapy, when I was in medical school, we have 5 drugs, mainly like Dilantin, Integratol, valproic acid, phenobarbital, mycilline, that was it. But then they were not the greatest in terms of side effects, and we came up with like 15 more different drugs in the last 20, 25 years. In the early days, when patients did not respond to one medicine, we tried another one, 2, 3 medicines, and several medicines were tried, and some patients were walking pharmacies, so to speak. And a lot of us decided, well, that's not the greatest idea. These patients are sleeping most of the time. So monotherapy became the choice treatment for epilepsy. Now, even after multiple drugs and multiple drug changes, patients remained intractable. And they were called the medically intractable patients. And they were the candidates for vagus nerve stimulation. Of course, for the medically intractable patients, temporal lobectomy was popularized in the 70s. Of course, Penfield actually did temporal lobectomies and topectomies in the brain in the 1930s, but it was very difficult, very expensive. Evaluation was not as precise, but it was in the 70s. Guess what? The video EEG recorder, the video tape is what made it all possible. We were able to record EEGs for a long time, record seizures and classify seizures and find out where they're coming from with the EEG electrodes and sometimes implanted electrodes. That made brain surgery like topectomies possible. Now, not everybody is a candidate for that. If you have a single focus, preferably in the right temporal lobe, that's the ideal candidate for temporal lobectomy. However, if you have multiple foci and they have failed multiple medications, vagus nerve stimulator is the next step, and it's less invasive, and a lot of patients do feel good with it and have fairly decent seizure control.
Well, thank you for that. We do have a couple more questions if we have 1 or 2 more minutes. The next question we have is, are there any long-term risks of repeated?
We can go past 10 minutes past the meeting is fine also. Sorry to interrupt.
No
Go
worries.
ahead.
So are there any long-term risks for repeated DBS stimulation?
Well, DBS is very safe. The immediate complication would be infection. There have been cases where the lead led to infection and had to be removed. Of course, then after treating the infection, you can reimplant or choose some other form of therapy, such as vagus nerve stimulator in those patients if they're scared to go back into the OR. So yeah, long-term complication for the stimulation itself, there aren't very many. Now, the leads can sometimes migrate, these are very tiny nuclei, and there is no anchoring that people can do so far except in the meninges, but that doesn't prevent the tip of the electrode from moving, and that can result in sometimes in tremors, dyskinesias, things of that nature. Other than that, it's pretty safe.
And another question we have is, does DBS improve mortality in Parkinson's disease?
No, not that I know of. You're the specialist in Parkinson's. Regardless of how you treat Parkinson's so far is a relentlessly progressive condition. Maybe you can answer that question.
Yeah, so I would agree with that statement in that the DBS helps with stiffness and slowness. Unfortunately, we can't really tell patients that it's going to reverse their disease or change what happens on a biological basis to their disease. Typically, patients with Parkinson's will ultimately become more akinetic and rigid, and then end up having dysphagia, which can result in pneumonia.
Yes, yeah.
Some of the
This
other
is
questions.
Rajan, so just a quick question, as we are speaking, one of my closest friend is having a deep brain stimulation, happening tomorrow in a Leahy Clinic in Boston, so that's why, so is there any studies which have showed any mortality, which difference in, or arresting the progression of this Parkinson's disease?
Sure. So unfortunately, it does remain a neurodegenerative condition for which we don't have any disease-modifying therapies. The best recommendations we make if we are looking for something that is disease-modifying would be something as simple as getting regular exercise, 2 to 3 hours a week of exercise focusing on strength training, balance training, and endurance training. But unfortunately, getting back to the biological basis of what causes Parkinson's disease, we don't have any active treatments.
And we don't have anything, because you said biological, there is so much of things with biologicals, but this doesn't have any autoimmune
Sure.
thing to the Parkinson's, right? So, is there any research going on, biologicals looking at, anything for Parkinson's?
Sure. So that may kind of go outside of the scope of this talk, but what I would tell you is that most of the research of how to treat Parkinson's disease in the future is more so geared towards treating what's probable, which is the genetics. Genetics and environmental factors play an immense role. And the general idea is that there's many different types of Parkinson's disease. You don't have one type of Parkinson's disease. You have hundreds of types of Parkinson's disease. There are early onset Parkinson's patients that mostly have tremors. You have postural instability gait disturbance form, which is very different, versus predominant dementia kind of associated with Parkinson's disease. So the idea is that there's going to be more targeted therapies, much in the same way that we don't treat all breast cancer patients in the same way today in 2025 as compared to 20 years ago. It's targeted towards the genes. Similarly, with Parkinson's disease, just in the past 15, 20 years, we have 66 different genes that are associated with Parkinson's disease. 20 years ago, we said that there was about 5.
Thank you for this explanation. Thank you.
We also need to understand that whatever treatment modality we choose for Parkinson's, we got to make sure we are treating Parkinson's disease. There is a group of conditions known as Parkinsonism, where there are other neurodegenerative conditions associated with Parkinson's, where it may look like Parkinson's, but may not necessarily be Parkinson's. So that's why you always need an expert, Dr. Alias, to evaluate those patients before you go on to therapies like deep brain stimulation.
Some of the other questions we have, any information about peripheral nerve stimulation?
Yes, of course.
Potential benefits in like fibromyalgia?
Not for fibromyalgia. Fibromyalgia is a condition that it's a matter of controversy. I do believe there are patients who have fibromyalgia, which is probably an autoimmune disorder that affects the marble in our muscles, and it's an inflammatory disease, probably from autoimmune inflammation of the fibrous tissue within the muscle itself. So I do believe that condition exists. But there is no specific treatment at this point in terms of neurostimulation, because what are you going to stimulate? It affects the entire musculoskeletal system.
Another question is there a role for neurostimulation in patients with motor neuron disease, like ALS, Lou Gehrig's disease?
It is a degenerative disease. It affects the motor neurons in primary lateral sclerosis, ALS, amyotrophic lateral sclerosis, and also in the true motor neuron disease, which affects the anterior horn cells like the Wolfart Koger-Belander disease. So those are degenerative diseases affecting the nerves themselves. It's not a localized disease except when it occurs in the spinal cord, like in a segmental way. So it's a larger process that affects the entire nervous system. So nothing that I know. Of course, there are autoimmune therapies that are coming on the market now for that, because some people believe it's an autoimmune condition.
All right, a couple more questions. Do these stimulators have to be turned off during general surgery and other kind of procedures?
Well, it depends on the surgeons know this better, and if there are surgeons in there, they can answer better than me. During surgery, the body is earthed. The body is connected to the earth itself. Yeah. So the current that we use for these stimulators is so small and sometimes so high frequency, it usually does not interfere. There was a fear at one time that cautery can be affected by, but it's pretty safe. We can turn it off. We can turn the whole thing off if that's necessary. One of the things we do for patients who go for MRI, we turn off the vagus nerve stimulator before the MRI is done, because the magnet can induce a current and fry the nerve.
Thank you. And one more question that was repeated, I think. What do you do with DBS, and if a patient has a pacemaker? And I guess I can answer that question. They will typically just put the DBS under the opposite clavicle, so it's not a major barrier. It just adjustment needs to be made with the wiring from the surgeon. I think that really covers most of the questions. My apologies if I missed anyone. Anyway, thank you very much, Dr. Oommen, for your great and informative lecture. And on behalf of AKMG, we'd appreciate you opening a window into this exciting new developments in neurology. The CME program in December will be held by Dr. Venkat Iyer, with details to follow.